Everywhere.
Yeah. You're live here.
Are we live?
Yeah.
All right. Terrific. Hello, everybody. Welcome to Fertility Fact or Fiction. I'm your host, Dr. Rahi Victory, fertility specialist, double board certified in Canada and in the US for reproductive endocrinology and infertility. And thank you for joining us on the show tonight. We have an interesting show tonight because I'm just going to review a couple of things we learned on our recent trip to the American Society of Reproductive Medicine, mainly focused on one area in particular, because there wasn't a whole lot of earth-shattering stuff that came out of that meeting. And then we'll talk about a new study that's going to be reviewed probably next week after we do some additional research around it. And then we're going to answer your questions. I apologize that I missed you last week, but I was at the American Society of Reproductive Medicine in New Orleans. If you haven't been to New Orleans, it's obnoxiously loud, like so loud it was uncomfortable, no matter where you went or what you did. But the food was amazing. And I met some good friends, Dr. Amy, the egg whisperer. I saw my very good friend, Millie Thakur, some old colleagues, and some new colleagues, and that was fantastic. I saw Millie Misra, who's running Bloom Fertility in Phoenix, Arizona. She looked every bit as lovely and brilliant as she always has. So yeah, it was great. I got a chance to connect with some old friends and see how people were doing and find out what was new and exciting. And had a wonderful dinner there with some colleagues from Canada, where we discussed use of Recavel, and I'm going to be visiting some clinics to talk to them about our protocols because they asked me to come after they heard how different the stuff we do is. So yeah, kind of cool, and a good meeting overall. Lots of stuff to learn and find out about. So thank you for joining us, and we'll briefly touch on what we learned at that meeting. The main thing that came out of that meeting was that we should stop labeling embryos as being mosaic. So I want to touch a little bit on mosaic embryos and talk about what it all means and what the data is showing now. So mosaic embryos come from the idea that some of the cells in an embryo may be abnormal. So when we do embryo biopsies, we are biopsying the portion of the embryo that is going to become the placenta. It's called the trophectoderm. And so you take a few of those cells, maybe 4 or 5, whatever it is, and you're sending them off for testing. They obviously don't individually test 4 or 5 cells. We have to amplify the DNA millions of times in a PCR machine in order to determine if we have enough DNA to even analyze. And then you look at the copies of the DNA, and then you say, okay, this embryo is normal or abnormal. Well, sometimes you get a population of cells that are normal and a population of cells that are abnormal. We don't actually know if that correlates with the embryo tissue itself, the baby tissue itself, because we're not biopsying the baby. We're biopsying the placenta. And so there are going to be times where the cells are coming out abnormal because the test is a mistake. Like all you got to do is misread one base pair and now you have millions of copies that are wrong. Or it could be that there genuinely are some cells that are normal and some cells that are abnormal. So the big question is being, well, if some of the cells are normal and some of the cells are not normal, what happens to the baby? Are these turning out to be normal babies or not? So there have been studies ongoing, and over the last year or two, people have more and more been talking about the fact that if you transfer these genetically questionable mosaic embryos, that they are getting live births. And in a relatively recent study, they actually demonstrated that the live birth rate was the same. And so a couple of articles or sort of manuscripts at this conference actually looked at this. And the best one, which was awesome, is from a company called Juno Genetics, where they don't report mosaics. They just report them as being normal or abnormal. And so if you have an aneuploid embryo where all the cells were abnormal, those are considered abnormal. But the rest of them are all lumped together as being normal. And so what they did was they let people transfer all these embryos thinking that they were completely normal. And then they went back and they analyzed it, looking at how many would have been called mosaic if they were reporting it as mosaic instead of just normal. And they actually had a huge number. So they had over 9,000 embryos transferred that were mosaic. So interestingly, when they analyzed their data, they showed that they had between a 50 to 60% success rate for the embryos that were genetically normal. Not amazing, but pretty average. We're getting a much higher rate here, but a reasonable success rate. I mean, no one's going to say that and say you're doing poorly. That's considered doing reasonably well. And when they looked at the mosaic embryos, it had the exact same success rate, like literally no difference. So they generated these things called receiver operating characteristic curves and ROC curve. And when they looked at the area under the curve, there was no statistically significant difference. So we're actually going to stop reporting mosaic embryos now because there's no value to doing so. You're getting the same outcome with a mosaic that you do with a euploid. So why would we bother naming it something different? We're just going to name them all the same. So super, super interesting information. Very, very cool. Critical for us to all be aware of and know. And so very, very kind of startling, game-changing info. And I think more and more people are going to move away from describing embryos as mosaic, and we're going to start describing them as being normal or abnormal. The other debate that I went to, which was interesting as part of that same presentation, I spoke to a gentleman there who pointed out two articles which I am delving into now, where essentially they showed that not doing PGT is a mistake, that you have a faster time to pregnancy, that you have a better outcome from doing PGT, and that it actually can be cost effective. Now, those are based on American studies. It's not the same cost in Canada, so I don't believe the cost effectiveness model holds. But there are people questioning whether we should be doing PGT or not, and this data seems to be showing that it may actually be beneficial to do PGT for everybody, not just the young patient or the older patients. So we're not quite there yet. I'm not going to jump in both feet yet because I want to make sure that that's the right thing, but we are probably moving in that direction where more and more we're going to be encouraging people to engage in PGT because it looks like the outcomes are better. In particular, there's one study where they had over 350,000 embryo transfers. So it was just this huge number, and they showed that the PGT statistically significantly improved the outcomes. So I think that there's something there for us to explore, and maybe we'll do it on a future Fact or Fiction or a YouTube video, but it's something we're delving into and we're going to analyze and study. I went to a bunch of talks on adenomyosis. I actually found those talks terrifying because I watched some surgical videos which scared the hell out of me. I would never do surgery like that. It seemed horrible. And then I listened to some of the talks. They were essentially doing like a very brief version of what we do, but not as good as what we do. So that I didn't find particularly helpful. And then I sat through some other talks looking at recurrent pregnancy loss. I didn't particularly learn anything new. There was nothing sort of mind-blowing that was going to be a game changer for anybody. There were apparently two talks on using PRP in the uterus and using Neupogen in the uterus, and supposedly they showed no benefit, but I need to look at those because there are many studies that have shown a benefit, so I don't know what the study design was and who it applied to. So that's something that should be kind of interesting to take a look at as well. So that was kind of what we learned from ASRM. Great food in New Orleans, horrible noise levels, like truly atrocious. Wonderful weather. The weather was amazing. And interesting meeting. I would challenge ASRM to maybe find a better venue next time. They literally didn't have enough room in the talks to get in. I was like standing room only, squeezed off to the side, like, chest to back to every single person because we were all crammed in together just to get enough space to hear what people were saying. But some really interesting stuff that came out of that. Was hoping for some exciting new tech or some exciting new kind of, product or something like that. Aside from the fact that we're going to be buying a automatic sperm analyzer, there wasn't anything that was particularly cool. But they actually have these machines about this big, like a big, I don't know, microwave size, right? And you put the sperm on a slide and you shove it in there and it tells you everything.
Really?
Yeah. You got to stain it and stuff, but it reads it for you. And you can actually have it done remotely, which is why we're doing it, because we have a bunch of satellites now. So I could set it up in our other clinics, and the computer here will analyze it and then spit the result out over there.
Wow.
Not cheap, but very cool. So that was the only thing that came out of that was kind of new. And
Mosaic's a pretty big one.
Mosaic was huge. I'm going to stop reporting mosaics. You're either going to be normal or you're not going to be normal. No more confusion about mosaics.
That's amazing.
That's cool. Yeah, I think so too. And kudos to the guy who did that study. I went up and spoke to him, and a young lady that also did research with them. I mean, that's impressive. They did a great job. So very, very cool. Yeah.
Ready?
I think so. Yeah. Tired but ready.
We'll start with YouTube.
Yeah.
Hi, Dr. V. What's the difference between tacrolimus and sirolimus? Is this recommended for endo patients? And how do you decide to use which one over the other? Thank you.
So there is a slight difference, and supposedly sirolimus is better than tacrolimus, but we can't get sirolimus easily in Canada, so we actually use tacrolimus. But I spoke to a hematologist from Europe who's actually a patient of mine, and he uses sirolimus all the time, and he actually recommended that we stick with the sirolimus. So I'm not sure what we're going to do in Canada. But yeah, the differences are slight, but they are there. So we should probably be using Siro, but we're probably using tacrol. It should be used for endo patients. We reviewed that on our last show 2 weeks ago, where we evaluated a study where they used tacrolimus or sirolimus for endo patients and showed a very, very big difference in all the outcomes. So it is something that should be considered. We're now integrating it into our endo protocols.
Nurse here, just wondering how you feel towards working night shifts after an FET. Should it be avoided for a certain period of time?
Yeah, so there is data. That's a great question. Thank you for your service. We appreciate all you do. There is data that demonstrates that people that work shift work where they're on at nights actually have lower fertility rates. So yes, if you can avoid doing night shift, you should. If you need a letter from your doctor, especially if it's me, I'm more than happy to write you a letter for that. So don't hesitate. I saw Soraya says that my eye is swollen. There is something wrong with my eye. I got something in this eye when I was at my cottage pressure washing something. And ever since then, it's slightly swollen. It used to hurt. The pain's gone, but it still looks a bit swollen.
A little bit swollen.
A little bit swollen,
Yeah,
right?
yeah,
I probably need to ice it. I don't know.
Can you talk about lupus anticoagulant?
Yeah, lupus anticoagulant or antiphospholipid antibody syndrome involves your blood's tendency to clot more easily. And you have to remember that when an embryo implants in the uterus, it's forming all sorts of tiny little blood vessels as it creates the placenta and the uterus interface. Those tiny little blood vessels are very susceptible to being clotted off. And so if you have lupus anticoagulant, even though it's an anticoagulant, you're actually procoagulant. And so you end up clotting more than normal, especially in your arteries. And so all those arterial blood vessels that are forming can clot off. And so the miscarriage rates are much higher. The preeclampsia rates are much higher. Stroke risk is higher. All of that stuff is significant. So there's varying opinions on this. But in our practice, we give all of our patients aspirin and heparin when they have a lupus anticoagulant or antiphospholipid antibody or evidence of actual lupus. And so those patients, in my mind, do better when they're anticoagulated. Great question, by the way.
Hi, Dr. Vinci. I just want to say a big thank you for your advice on doing a letrozole cycle versus a hormone replacement cycle. And I am happy to say that I am pregnant.
Oh, wicked. I love those stories. That's awesome. Yes.
Good stuff.
Soraya is super excited tonight.
I like it.
Hi, Soraya. Thank you for being so wonderful to us every week.
See, she's great. Dr. V,
Yeah.
my LDL came back
Okay.
sky high, and doc wants me to statins ASAP.
Okay.
I'm 38 and it's genetic. How does this fit in with TTC?
You can't be on an anti-hypercholesterolemic agent and TTC, so you have to diet control rather than be on a statin. You cannot be on a statin and try and get pregnant because you actually need cholesterol for the placenta to create hormones. So that's not going to work. So for sure, don't be on a statin while you're TTC. Exercise, which will burn off a lot of the cholesterol. And then make sure that you are eating super healthy, like very low fat. Obviously, do it in conjunction with your physician, but you cannot be on a statin and try and get pregnant.
Hi, Dr. VNT. How long should you be taking tacrol before an FET?
Well, that's a good question. So in the study that we reviewed, which was a Chinese study, they did it for 3 months before IVF, but they were including and did not specify if it was the stim or the frozen embryo transfer. So it's a little hard to know. We typically do it 2 days before the embryo transfer and for 14 days after, so a total of 16 days. But I think from now on for our endo patients, we're probably going to do it a week before and 2 weeks after, so 3 weeks total. But no one knows for sure. So this is like newfound territory.
Love this show.
Oh, great. We love the show too. Tarek and I missed each other last week because we didn't get a chance to see each other.
It's a big loss.
My
whole week is out of fun.
I know. I felt the loss too. Yeah. I missed you, buddy.
For FET down regulation,
Yeah.
what cycle day do you start Lupron?
21 to 23. That's a good one. I like the easy questions.
There you go. And letrozole consistently thins my lining. Do you still recommend using it for modified natural FET or just do a natural?
Yeah, I mean, if it's consistently thinning your lining, I'd probably do a modified natural or just a pure natural. You could do letrozole and add in a tiny bit of estrogen, but I'd probably just do a natural and see how you do. One size never fits all in fertility. So, there's a study that clearly shows that estrogen priming is useless and probably detrimental because it cuts your chances down. It doesn't mean we can't use estrogen priming for anybody. There are patients that do better with estrogen priming. So if you take a study and you just say this study applies to everybody, you're being foolish because the human body's, miraculous. And there's never one size fits all. You have to be willing to understand the biology of each patient and understand that different patients are going to react differently. So we really focus on individualized care. So yeah, I mean, if you're getting a thinner lining with letrozole, don't use letrozole. That's a no-brainer for sure.
Regarding the research or your observation,
Yeah.
is this for low-level mosaics?
So they actually looked at all mosaics. When they broke it down into individual categories, it was only the high-level whole chromosome mosaics that didn't do as well. They had still a reasonable chance. I think it was 20%, but it wasn't as high as the other ones. But all the other ones, even the high-level segmental, they said they did the same. Study hasn't been published yet, so keep that in mind. It probably needs to go through several iterations of data and so on, but they presented it, and I'm sure it's going to come out in a publication soon. And that was very impressive data. Super impressive data. 9,000 embryo transfers where the doc didn't know. The doc thought the embryo was normal. So you're like eliminating all the bias, right? Mm-hmm. So they ruined the embryo. No difference between the ones that were euploid and the mosaics. Huge. Yeah, like game changer. Again, they didn't have the highest success rate ever, but that's because they were taking all the different centers that were doing it. And the average was 50 to 60%. So, with the mosaics, it was the same. Now, we're getting a much higher rate than 50 to 60% with one genetically normal embryo. So we're going to have to look at our data after we transfer the mosaics and look back and say, are we getting 50 to 60 and we're getting 82.3 with the euploids, or are we getting the same rate, the whole way through? So that's probably going to take us a year or two to accumulate enough data, but it'll be interesting to look at for sure. And either way, it's still a great success rate. How's your tea?
Love it.
I like this tea.
I like this.
It's a good tea. Yeah.
How long before planning pregnancy to start prenatal vitamins?
1 month.
Nice one. High octane.
Easy.
Can iron deficiency levels at 29 be a cause for miscarriage? Had 3 misses all 6 to 7 weeks, and blood work from my OB and genetic tests came back normal. That's the question.
No, unlikely. I mean, I would get a consult with a reproductive endocrinologist and see what's wrong, or a reproductive immunologist and see what's wrong, because we would most likely find out that there's something else going on. In all likelihood, it's something related to a bacteria in your uterus, or related to infections, in the cervix or in the vagina, or bacterial imbalance. We may end up finding that there are issues with your immunological system, or very likely your partner's sperm. Guys with high DNA fragmentation have a huge increase in the risk of miscarriage for their partner. If your partner's smoking, drinking, using marijuana, huge increases. So even if they're obese, if the male is obese, the chance of miscarriage is higher. So all of these things are huge factors, and we got to look at the guy, and we got to look at the lady, and we got to figure out what's going on.
How much can stress truly affect your chances of getting pregnant?
So obviously we all know no one should ever be told just relax and you'll get pregnant. However, stress is known to cause problems. So especially if you're very stressed, it can alter your hormone levels. And certainly we know, as I mentioned earlier, shift work can alter your hormone levels and affect your fertility. So does it impact it? Yes. How much? There are studies that show that there is a 60% reduction in your fertility for patients that are very stressed. So it can be huge. To be honest with you, you need a fertility center that has a robust program for mental health. I think we're probably the leaders in that. We've got social work, we've got psychologists, we've got a group session. We support fertility coaches. So we've got the London Fertility Concierge. We've got Fertility Blooms. There's all sorts of people we work with who can provide you with additional care. We've got our naturopath. We've got a family doc. We got everybody for counseling and support. Elizabeth King, who we worked with and did a show with as well. So there are loads of people that can be supportive and help you through your journey. And traditional Chinese medicine specialists as well. So I'm a big believer that the more support you have, the better off you are. Reducing your stress is huge. A good example, there is ironclad evidence that doing yoga improves your fertility. And the reason yoga works is probably through a combination of reducing your stress and improving your blood flow. So, something simple like that is proof positive that your stress levels can actually have a significant impact, and that reducing them can improve your outcomes. So yeah, it has an impact for sure.
How do Lutein and Luteinol work together? Can they shut down your ovaries and not allow for modified natural transfer?
So they work by suppressing your brain's stimulation of your ovaries to produce an egg so that you get very low estrogen. And then the peripheral estrogen that's being converted gets blocked by the letrozole. So you're really trying to shut off estrogen production or minimize it as much as possible. Can it prevent the lining from thickening? Sure. In some people, they're over-suppressed. But that's why we use a smidgen of estrogen in some cases, genuinely very, very little, and then we go ahead. Now, some people just don't respond and they need to get more estrogen, but we try and keep that as low as humanly possible in as many cases as possible.
Seen any data from Columbia U rapamycin study? Did they offer data on Spermidine? I guess that's a question.
So there is a rapamycin study which suggests that rapamycin might be very helpful for improving fertility outcomes. I've only seen the one study, but we are going to continue looking into it.
A lot of questions.
Perfect. We like lots of questions.
I'm just trying to make sure I go in some sort of sequence. Rotate properly.
I got an easy one. TikTok.
Okay, sure.
Is there anything to take for a cough or cold when you're pregnant? Yep. You can take Hall's Candies and Vicks Vapor Rub. Any cough syrup that says DM for dextromethorphan, but don't take anything that says decongestant.
I like to go with honey, some lemon tea, and some ginger.
That works too.
I hear that's a killer.
It is good. Yeah.
That is good stuff.
Yeah.
And I go hardcore on vitamin C.
Vitamin C, vitamin D.
Big time. Like, the 1,000 milligrams?
Yeah.
The minute I feel somewhat sick.
You take some?
Take 2.
Take 2.
The next day I'm healthy, like whatever's the healthiest thing you know.
Really?
Oh, yeah. Consistently. The minute I feel somewhat ill, I'm not sick yet. I'm like, throat, a little bit of 2 vitamin C pills.
2,000 and you're good.
Call me the next day.
Wow, that's impressive.
Now, that's not doctor advice or anything, but experience.
Next question says, do we ever refer to dietitians? All the time, and we are linking our website, we got to talk about that, by the way, to a dietitian that we're starting to work with who's amazing, and I love her website. So we got to talk about that. I think I sent that to you.
The dietitian one? Yeah.
We got
I had to think of the other day as well with the forms and stuff.
Yeah.
I updated the form part.
Okay, cool. Excellent. So it's working now.
Yeah. Well, it was always working, but it was just at the bottom versus the top.
So now it doesn't say book an appointment.
Yeah. Book an appointment. Request a consultation.
So now it just says request a consultation. Yeah. We got rid of book an appointment? Okay. All right, cool. Excellent.
Won't leave you hanging, man. Hello, Dr. V. What is your opinion on urea plasma causing RPL or RIF?
Yeah, it does. So there's lots of data for that now to support the concept that if it's in your uterus, it does. And so we use Fertility testing for that. Cervical check is not enough. It can still be in your uterus, even though if you're negative on a swab. So we use the PCR testing from Fertility to be able to distinguish, and I think it makes a huge difference, night and day.
So we got a new user on TikTok that I don't recognize. She's doing her first cycle from the looks of it, and she wants to know her chances of getting pregnant.
Okay.
Do
I have details?
No, I think this is first time.
Cool. Well, welcome to the show. I need details: age, BMI, partner sperm quality, your medical history. Even then, it's very difficult to give people their chances, but it depends what it is. Soraya's, I'm still here, and she's holding up her hand. Does she have a question?
No, she doesn't have a question. She just gave you that really good comment about your eyes.
Yeah.
And kisses from Holland.
Kisses from Holland. We like kisses from Holland. Yeah.
I accept all kisses from Holland. And then. And we know she's still here.
All kisses. We gotta have a talk with your wife, buddy.
No, we don't. What happens in the office stays in the
office. What happens in Holland stays in Holland.
That's right.
Yeah, probably a good thing in Amsterdam, man.
Whole other scene.
Yeah.
If your FET fails after Lupron down regulation.
Yeah.
How long after?
3 to 6 months.
Okay.
It lasts 3 to 6 months. That's what they want to know. So if you've been down-regulated for 3 months, we'll let you go 3 to 6 months before we talk about re-down-regulating you, because it's horrible what we do to patients with the Lupron letrozole. Like it's horrible. So yes, it works, and yes, it's good for the chances of success, but it's not friendly, and none of our patients like it. Yeah. I think you got kisses from Soraya.
I got lucky today.
Yeah.
Any recommendations for an FET protocol? All embryos are euploids made by DEs. We've had 3 chemicals and 1 failed implant. Sono normal, negative for endometritis. Previous on lupo deep for the last 4 months, endo lap done.
Oh, well, you need our endo protocol. We're getting a video coming out. Dark and I just recorded it. So 3 months of Lupron and Letrozole. Lupron alone is not enough. Try and take very little estrogen at all. If none is best, but if you have to, very, very little, 1 or 2 milligrams a day.